It is a nationwide crisis impacting every one of us. Opioids, legal and illegal, they're addictive and deadly.
This epidemic is a national health emergency.
Lives are being lost by the tens of thousands every year to painkiller abuse and heroin. The financial impact is in the billions. Opioid issues knife across each state, endangering every American city, suburb, and town, all cut deeply by the opioid epidemic. Eric Bowling lost his son to the synthetic opioid fentanyl at his Colorado University.
We must commit to removing the stigma of shame that comes with addiction and helping change public opinion so that people find evidence-based treatment before it's too late.
Stand up and fight the opioid crisis now. This is a Your Voice, Your Future town hall. Opioids, a national crisis. Now, Eric Bowling.
Hey Salt Lake, I'm Eric Bowling. I'm here in D.C., but I wish I was with you for our 14th town hall on opioids, the dangers of opioids. On September 8th of 2017, I got a phone call from a young lady crying. I said, Kelsey, is Eric still alive? And she said no, she was crying. He was a sophomore at University of Colorado. He took a pill on campus that he thought was a Xanax, and it was laced with fentanyl. It was a street drug that he shouldn't have done, and it killed him that night. That was about a year and a half ago, and since then, I've made it kind of a mission of mine to raise the awareness about opioids, the dangers of opioids, the addictive nature of opioids. The White House has gotten involved as well. The President and First Lady this week traveled to Atlanta to talk about those dangers. Sinclair has been phenomenal. As I said, 14 town halls around the country. Again, I wish I was there with you. I'm here, but we will continue the fight against opioid addiction and opioid overdose deaths. Back to you, Jim.
And now here in Salt Lake City, thank you very much for joining us for our Your Voice, Your Future town hall on the national opioid crisis. I am your host, Jim Spiewak. I am an anchor and a reporter here in Salt Lake, and I report as part of our Addicted Utah series. The project uncovers the many layers of opioid addiction. And we often think about, is there any way to control an epidemic? Well, to do that, it requires an understanding of human behavior and why people act the way they do in certain circumstances. And there's that in many forms that we will be talking about today during this town hall. Which brings me to our first story on addiction. The headlines are always, someone has died because of an overdose. But what about the people who have overdosed and did not die? We wanted to answer, how many people has that happened to? We found out the numbers are staggering. We call them the walking wounded, people who in many cases are alive but are not living. Here are their stories.
When I would use, I had nothing better to do, and I would just, go ask people for money and come back, and then I would just basically pass out.
A walk downtown with an addict. So you would buy drugs right there?
Oh, yeah. Majority that was down there, right at the opening of that is where they would be.
Allie York's drug use became more expensive than the cheap motels she would live in. And more important, where would you sleep?
Right there on the sidewalk.
So basically on this sidewalk that we're on right now.
Yep.
Allie wasn't always homeless or addicted to drugs. She grew up privileged. Faith was in her life, but early on she knew she was gay.
I didn't really know how to feel. It was very conflicting, so the opiates just made me feel okay.
Allie took her first opioid, a Loratab, at 16 years old.
And it had progressed that drastic to Oxycontin in probably a matter of 6 months. It was very, very quick for me.
She would convince her friends to give her leftover prescriptions, but it wasn't enough for the now 19-year-old.
I would rob people. I would steal. I would pawn things from my parents.
Her pill addiction, now up to $300 a day, Allie needed a cheaper high.
And I had somebody that was in addiction explain to me that there really wasn't much difference, that, Oxycontin and heroin are basically the exact same thing.
Allie also abused alcohol, which almost killed her. She recalls waking up in the hospital with a nurse at her bedside.
She proceeded to tell me what, my blood alcohol content was, and it was a 0.52, and that I was a miracle that I had survived.
Since 2016, Utah was one of 33 states to receive more than $12 million specifically for overdose preventative resources. Yet over that same time, non-fatal overdoses have gone up each year.
How many overdose calls have you been on in those 4 years?
Probably 300 or 400.
11,814 people have needed help for an overdose by a Utah first responder since 2016. These are people who did not die. About 40% of those happened in the Salt Lake Metro, the area paramedic Garrett Wood works in.
It's not surprising that there's that many. I think there's probably more. I mean, it comes in waves, but some seasons we'll go on 10 plus a day.
Utah was one of just 4 states the CDC says saw a significant increase in opioid and all drug-related non-fatal overdoses. Wood says they happen everywhere.
We'll go into a church, we'll go into a penthouse. You know, it's everything.
And I got that to represent.
A story Allie knows all too well as she's back walking the streets she once lived on, this time sober.
Do you still feel like you're a walking wounded?
It's different. It's a different walking wounded. I think I'm on the recovering side of that walking wounded. It's no longer the same pain and that same feeling.
Joining me now, Dr. Jennifer Plum, you are with Utah Naloxone.
I am.
Thank you very much for joining us as part of this town hall. First off, talk to us about what is Utah Naloxone?
Well, Utah Naloxone is an organization that was founded by my brother and myself. We lost our brother to a heroin overdose in 1996. So 22 plus years ago. And we lamented that at the time he died, the resuscitation medicine, or the antidote naloxone, Narcan, it's also known, was not present. And the people he was with were too scared to call 911, and he didn't get a chance. So we wanted to find a way to empower community members, families, friends, folks who work within their community in different settings, law enforcement. We wanted to empower them to be able to save lives. And we founded this organization with that intent, to increase education, awareness, acceptance, and access to naloxone.
How do you best do that?
You know, for me, watching it go out, it really has been a matter of, first of all, having this be accepted. When we started talking about naloxone, I would say I started in about 2010 in the state of Utah, and people kind of shook their heads. They weren't sure that was okay. And as the years went forward and we got more stories from families and from people who were here with us because naloxone had saved them, and we demonstrated that we really could save lives, that people who typically aren't thought of as lifesavers could save lives. We're talking about moms and dads, and we're talking about spouses and friends and everyday bystanders. We're talking about law enforcement officers who took on an additional role in their already overloaded toolkit because they wanted to save lives. And as we've rolled it out, we just have to find ways now to get it in people's hands and to make people understand how important it is to have it.
Now, naloxone, correct me if I'm wrong, it counteracts the agent that opioid does to our bodies.
Exactly.
Correct?
It's a pure antagonist. The only thing that it does is reverse an overdose. Can't get high with it, can't get addicted to it, can't relieve pain with it, can't overdose on it. Only thing you can do is reverse an overdose by getting it to someone in time. And that's really where the saves are, because when you overdose on an opioid, you're not breathing. And that means no oxygen. As little as 3 minutes without oxygen, you're losing brain cells. So to me, a first responder means the first person there. And that means equip as many people who may be around someone at risk, because they are the true first responder.
An EMT paramedic might not be the first responder
right.
in every situation.
Even when they're on their way, there are precious minutes ticking away. In some of our more rural settings, that can be 20, 30 minutes. You don't have that kind of time for someone. So it purely is, it truly is, I've heard it called the Lazarus drug. It purely has that one job to bring people back to life when they're on their way out.
Now, you started Utah Naloxone at a very critical time in the opioid epidemic. That is around the time that synthetic, man-made opioids, as we now know as pills today, which we will talk about, they really started to come on the scene around that time. You said you lost a loved one to heroin,
right.
But these synthetic man-made pills have really played a big part.
Well, and it's interesting for me, and I'm an ER doc, and so I think about things from a very kind of basic strategies. And for me, if something leads to overdose the same way, and I treat it the same way, and it unfortunately leads to death the same way, I think of it the same. Heroin and our synthetic opioids, which are what are in our OxyContin pills and our other pills that are out there, as well as fentanyl that you hear about, they're all in the same family. And so you're right, there has been this kind of progression of which substances are more likely to make someone at risk because it's what's out in the community, but none of them is more dangerous than the other. And I personally have seen overdoses in children, of all of the kinds that are out there, whether that's one of our synthetic fentanyls, whether that's Lortabs, whether that's OxyContins, whether that's heroin. I've seen it in all of them. So it is absolutely crucial, and it's a big part of the message that people realize an opioid is an opioid is an opioid. There really isn't a need to say, oh, well, that one kind or this one kind. They are all very, very chemically similar.
We're taking some questions from our audience today. One of the big questions that they asked is, how do you get naloxone?
Sure. So you can ask us for one. We have them here for anyone who's here today. But one of the most important ways to get naloxone is to find out who in your community has it. So pharmacies are an option. There is a standing order law passed here in the state, which means participating pharmacies you can go into, ask for without a prescription. But there's sometimes some stigmatization and people feel uncomfortable with that. That also requires resources, right? Money. So an injectable kit, which is the gold standard since 1971, they're about $50. My copay on insurance is $10. There's an intranasal form, which is about $150, $30 on my copay. There's a very expensive one that talks to you. I don't prescribe that one. There's also, though, the ability to go into community-based organizations. So we have partnerships, say, for example, at USARA, which is one of our great advocate groups. In fact, I think you're talking with a couple of their folks today, where you can walk into their centers and get them. You can go into Salt Lake County, all of the 18 Salt Lake County libraries. You can go in, they don't take your name, they ask you what information you need to know, and they'll teach you how to use it, and you'll leave with a kit. You can always call us at Utah Naloxone, and we'll make sure people get them, because we realize there's a lot of mainstream thinking that went into planning for naloxone access, like a flu shot. If I put it in the health department and I put it in the pharmacy and I put it in the doctor's office, it'll just be available to everyone and it'll be great. And we learned really quickly that it needs more than that. We need places where people feel safe and secure and non-judged and not worry about being put on a list. And so that for us is the goal, as broad as we can get it to be.
And even first responders, EMTs, firefighters, I've reported on this before, they will hand them out to people that are just standing around someone that they're treating for an overdose and say, if this happens again, here's some naloxone.
And here's what you need to know. Exactly. In fact, one of my favorite stories, we have about 6, now coming up on 7 different EMS agencies in the Salt Lake Valley that'll do that, because that parent or that friend or that whomever has just seen the medicine work and say, all right, you need to have this around. Here's how you use it, here's a kit, because putting it in their hand is the goal. And one of my favorite stories was when Salt Lake City Fire first started doing their Leave On Scene program, someone chased them down. They were chasing them down after, hey, can we get some of that naloxone stuff? Which to me that's exactly what I want, people to feel comfortable reaching out and asking.
What are the signs of an overdose? We now just talked about how you counter an overdose. Right. If someone has never seen someone overdose, what does it look like? The things that I teach people, there's 5 things that I teach people to recognize, because in a terrifying moment of coming upon someone not responsive and they really look like they're not with us, not talking to you, not moving are the first 2. So this isn't someone who's kind of maybe nodded and slurred. That person's dosed, but not overdosed. Not talking to you, not moving. Then I want you to look at eyes, lips, and lungs. Simple as that. Eyes, when you have an opioid in your system, you get these pinpoint, tiny, tiny fleck of pepper pupils. If I were to find someone down anywhere around us right now, hey buddy, wake up, and we couldn't, and I popped open his eye and it was a tiny little pupil, that's opioids, period. But say you couldn't see their eyes, it was too dark, their eyes were too dark, look at their lips, because remember I said they're not breathing, they're gonna get bluish, grayish, and then look at their lungs. They're either not breathing at all, they're breathing a very little bit, or they have this awful snoring sound. So not talking, not moving, look at their eyes, their lips, and their lungs. And you immediately, if you find someone like that, you can't wake them up, hit 911 on your phone, put it on speakerphone, and start getting ready to give them naloxone. Also rescue breathe for them. They're not breathing. Having someone breathe for them is absolutely going to help them. And with just that knowledge right there, and just a kit like this, since July of 2015, over 3,000 Utahns have stepped in and saved somebody's life, which is pretty amazing and also pretty terrifying. You just talked about some of those numbers right there. Yeah. How effective is it though, really? Does it work every time? Do we know that?
If you get to someone in time, it absolutely will work every time.
How much time do we have to get to that?
Well, and that's part of the challenge, is that in the past we used to talk about having hours to get to someone with a heroin overdose or a pill overdose. And with the emergence of fentanyl, it's probably much less than that.
Fentanyl is, for those that don't know.
Oh yeah, so fentanyl is something you'll hear about. It's another synthetic opioid. We actually use it in the medical field, but there are counterfeit fentanyls that are coming into our communities, and they're finding their way into pills. They're also finding their way into heroin and other substances. And it's a much faster acting and much stronger synthetic opioid. And so the thinking is, when we used to have hours, we truly maybe only have minutes now to get someone breathing. And that even amplifies the importance of more naloxone being out there.
So time is really of the essence.
Time is crucial, and that first responder, we talk about lifesavers, right? And you think about a doctor, or you think about an EMT or a paramedic, or you think about law enforcement. Lifesaver is that person right there, right then.
All right.
Simple as that.
Dr. Jennifer Plum, thank you very much for your insight on
so
naloxone.
much.
We appreciate it. So thank you very much. Coming up next, we've talked about opioids, but there is another crisis on the horizon. Remember this word, benzodiazepine. We'll tell you what they are and why they can be so dangerous coming up.
Anything to get my mind off of the pain.
6 years in the Marine Corps wears on veteran Miranda McClurg's body every day.
I had hurt my back while I was in, and so I was having some back pain.
The pain never went away. Finally, her tolerance did, and McClurg started taking opioids.
They actually make your pain worse the longer you're on them, and you have to keep going up and up on your dosages.
McClurg hated the way they made her feel. It was time to get help.
I was not happy to be in that group.
We're not here to taper your opioid medications.
McClurg reluctantly enrolled in a brand new pain management program offered at the Salt Lake VA.
Our program is kind of a grassroots program.
Jamie Clinton Lant is a nurse practitioner at the Salt Lake VA. She helped create the curriculum.
Our veterans are twice as likely to die from an accidental overdose. This is what we do here.
In 60 minutes, patients are evaluated, risk factors and expectations are explained. They teach veterans how to live with opioids.
The goal is not to get patients off opioids. The goal is to keep them functional, and that may be with opioids.
Jamie says the program helps 95% of patients. Before, she estimates it was about 1/3.
It doesn't take away any past losses, but it makes me feel like I'm moving in the right direction.
The program is mandatory for any veteran that has been on opioids for longer than 3 months and has chronic non-cancer pain.
We're dealing with the body, but we're also dealing with what with the mind. We want a whole person approach.
That's done through pain management classes like yoga, cognitive behavioral therapy, and teaching mindfulness.
There's a paradigm shift in how healthcare is going, and that's towards the entire person.
These people kind of know what they're talking about.
Which McClurg learned in the program she once didn't want to take, but because she did, she no longer takes opioids.
I still have pain, but it's pain that I can manage.
Welcome back to the Your Voice, Your Future Opioids, a national town hall crisis. I am Jim Spiewak. I am your host here in Salt Lake City. Opioids, they're the crisis that we have all been talking about. But there is another crisis looming. It's on the horizon, according to many experts. Benzodiazepine, it's a Schedule IV drug, and it is thought to have a low potential for abuse. But we found out there are some dangers if patients do not come off of benzodiazepines in the right way. It is called withdrawal syndrome. Here is what we found out about benzodiazepines.
Why don't you just put your regular shoes on, sweetheart? Okay. Maybe they're right. Maybe I'm broken. Well, yes, wear socks too. Something's wrong with me. Maybe I've got depression or anxiety, or I just can't handle being a mom anymore for some reason. Do you want to watch something?
Jocelyn Peterson lives a busy life. One she started to think was bringing on depression or anxiety.
I couldn't read. I was losing weight rapidly. I couldn't eat. It was just really bad. I was dizzy all the time.
But instead, she was diagnosed with insomnia and was prescribed lorazepam. It's a benzodiazepine, also known as a benzo.
I'd spent 4 months being completely incapacitated, and like that, all of a sudden I was better.
Benzos are typically used to treat anxiety and are only supposed to be used for a short period of time.
The problem is that while opiate withdrawals won't kill you, benzodiazepines will.
The withdrawal is supposed to be slow and methodical. In the care of a doctor, Peterson tried to quit cold turkey. It almost killed her.
It was so excruciatingly painful to get off. I just couldn't go any faster.
Are benzos addictive?
Absolutely. And we've known that since they've been around.
Dr. Kai Dorsey is the chief of psychiatry at McKay-D Hospital. He says the brain develops an emotional dependency on benzos.
When you try to come off of it, you feel anxious, and so you think, I need more of it.
As the dependency builds, so does the danger of getting off.
The withdrawal syndrome can actually kill you. It can cause your heart rate to go up, your blood pressure to go up to the point where you die.
Since 2016, the University of Utah Health prescribed nearly 206,000 benzo prescriptions and refills. Intermountain Health told us they would need a team to gather and validate their information, and Mountain Star only tracks benzos given in a hospital. They did not provide us their data, saying it would be too difficult to explain to the public.
In your opinion, do you think these are being overprescribed?
I do. When I see patients come in and they've been on them for 10, 15, 20 years and never had a discussion with a doctor previously about coming off of them, that tells me that there's an issue here.
The opioid epidemic concerns me because it is the current crisis. The crisis on the horizon is benzos.
In 2016, the CDC issued new guidelines for doctors to not prescribe benzos with opioids. But that's exactly what DEA agent in charge in Utah, Brian Besser, says is happening on the streets.
What the average consumer doesn't know is they're holding in their hands Russian roulette. You mix it all together, and you've got a deadly cocktail that's killing thousands of Utahns.
Good luck. Good luck.
Which is a fate Peterson works hard at every day to avoid.
I would rather die than take another benzo again.
Joining me now is Brian Besser, who was just featured in that story that you just saw. He is the special agent in charge with the DEA here in the state of Utah. Also joining me is the Assistant Attorney General, Scott Reed. And Scott, you're also the chair of the Opioid Task Force. So we've got two of the best law enforcement minds right now in the state. Brian, I'd like to start with you first off. With the work that you do over at the DEA, what do you see as some of the main contributing factors to the opioid crisis?
Wow, this is the opioid crisis, the current public health crisis is such a variegated issue. Here in Utah, I'm seeing three predominant things that seem to be fueling the opioid crisis, at least here locally. Number one, sadly, Utahns have a insatiable appetite for prescription pills. We have a lot of prescription pill abuse in the state. You know, from a macro standpoint, the United States has an insatiable appetite for drugs right now. In Utah, at a micro angle here, that's exactly what we're seeing. Because there is this affinity towards prescription pill abuse in the state, the cartels, quite frankly, have capitalized on that. They have. You know, their goal is to make money. It is a greed-driven and a profit-driven enterprise, just as simple as that. You and I have spoken about that before. So the cartels look and they want to find out where they're going to be putting their heroin, and they're going to put it where prescription pills are being abused. They're putting their good quality heroin here. The third issue, Jim, is the fact that we are seeing this advent of synthetic analogs popping up like counterfeit fentanyl pills.
Yeah, and Scott, Brian just talked about the cartels and the fact that there's an insatiable appetite for these drugs. On the prosecution side and on the legal side, how difficult is it to prosecute?
Well, to go back to what Brian was saying, we have essentially three sources for opioids: the domestically produced, what we refer to as prescription opioids, and they've been with us for a long time. They certainly serve important medical purposes, but at the same time, it's been part of that developed the demand within our country, and Brian talks about insatiable demand, and there's really no other way to describe it. So beyond domestically produced, legitimate prescription opioids, we have heroin, and the president in his speech in Atlanta notified us that about 90% of our heroin is coming into the United States across our southern border and resulting in approximately 300 overdose deaths a week. And so if you compare that to overdose deaths overall, and you're talking opioid overdose death rates in the country at about 130 a day, heroin occupies about 40% of that space.
So what legislation then is helping fight the opioid crisis?
Well, the Congress, of course, has been working on things going back to the Comprehensive Addiction and Recovery Act of 2016, signed by President Obama. Since then, I think every state in their own way has tried to address the local problem. Our legislature has been very active. I think that their important function for us is to give us tools in the field and to reduce barriers. And the more we work on these problems, the more barriers we identify and the more opportunities to then turn around and collaborate and partner, as Dr. Plum talked about earlier, because I think that's the key. Here in Utah, we are a close-knit state, a tight state. 3 million people sounds like a lot, but we really work well together across the board. And I think collaboration and partnership and leadership from the legislature, but the opportunity to then implement things that are going to help folks in the long run is really the key.
And taking a question from the audience, Brian, for you on the law enforcement side with your work at the DEA, have you noticed a correlation between reduced opioid prescriptions, related deaths, and those types of deaths, and an increase in heroin overdose fatalities?
I haven't noticed a market increase, I would say. You know, it's interesting, 80% of our individuals that we've been able to determine who are struggling with heroin addiction on the street started with prescription pills. So, you know, there's obviously a correlation there. As prescription pill abuse seems to go down, innately you will see certain individuals who need that psychotropic effect, that psychoactive effect of a Schedule II narcotic. It's cheaper, heroin's cheaper, it's more readily available, and obviously oftentimes it's more potent, but the risk is exponentially higher.
And you have also worked in several DEA offices across the country. Briefly give us just a sense of how each one is a little bit different in your work.
You know, again, the United States, it's not one size that fits all. I've had the opportunity to work in the South, I've worked in New York, I've worked in Chicago, I've worked in the Midwest, and now I work here in the West. And each area has its own interesting demographics and geographics that come into play. What's interesting here in the West is our rural areas, our wide open spaces, our thoroughfares that are capitalized on by drug traffickers. They feel that they can, you know, capitalize on our wide open spaces and courier our drugs through our state, and that makes us very susceptible to being a transshipment point for heroin.
Yeah, another question from the audience. Scott, what can the average person do to help address this opioid epidemic?
Well, I think you have to understand, as Dr. Plum was talking about earlier, some of the signs, the individual signs, not only of overdose, but of substance use disorder. I think this is something that we all understand now has touched every one of us in some way, in some capacity, our friends, our neighbors, you know, people in our workplace. And so I think you need to educate yourself and kind of step out of the shadows. Brian talks about this a lot, about the stigma and the shame related to particularly prescription abuse, because these are things given to us by our doctors. How can they be bad for us? But we have to be able to talk about the realities of that and to be able to identify that this is an unprecedented time for all of us. We need more than ever to work together, concerted effort, to understand and to defeat the problem as a community.
From the state level, are you getting enough help from the federal level? Could you be using more?
Well, help comes generally from our federal partners in the form of money, and I think access to the money and knowing how to tap into that is really key for our success. We could do better in finding, you know, the ultimate delivery points for those things, but the money's been made available, and I think our state agencies are taking full advantage of that, again, within a population that really understands bang for your buck and getting more out of your dollar and collaborating, as we talked about earlier.
And does part of that go to that opioid task force, and what is the work that the task force is doing?
Well, the task force is more of a broad-based interdisciplinary group of professionals who focus on partnership and who identify problems and help to address problems through other mediums. So we're not really funded by any source, but we're a group of, Brian's one of the co-chairs, General Reyes is a co-chair, and our U.S. Senator Mike Lee is the co-chair of the group. And we have really talented folks who can understand and identify where we're headed.
And then, Brian, you have the ability through your resources, you listen into phone conversations to some of these criminal activity networks. What are they saying?
Well, you know, it's interesting. Again, like I said, it's a greed-driven and a profit-driven enterprise. Oftentimes, you can become rather calloused when you hear these individuals transact. It's you know, evil walks amongst us, right? We live in a world where we have nefarious people, evil people who want to profiteer off other folks' misery. I hear that. You know, the biggest thing that I hear right now, especially from a local level, is the concept, you know, oftentimes that Utah can be a cartel-friendly state, right? We've talked about this before in an upcoming segment, where the state itself, its geographics, its demographics lean favorably for them to doing their business, and we want to step in and help prevent that.
All right. Brian Besser with the DEA's office and Scott Reed with the Attorney General's office. Thank you very much, gentlemen. Very interesting insight. We appreciate you being here.
Thank you.
Thank you very much. All right, coming up next, we speak with a woman who lost a son to an opioid overdose, and we also speak with a woman who is in recovery right now. You're going to hear how she got addicted and how she is beating her addiction and in recovery. That's coming up next.
The job can be very, very, very stressful and triggering at times.
The job is to help addicts become recovering addicts.
Our job is to relate with the clients on a level to create trust and connection.
Ellie York, recently highlighted on 2 News' Addicted Utah, has been sober for more than a year. She now works at Steps Recovery Center.
There's a lot of experience to come to the table, you know.
What is now 10 facilities helping 270 addicts get clean started as 1 location and 3 people a decade ago.
Some people never get there. Chase it to the depths of insanity or death.
Mike Jorgensen is a recovering addict. He started Steps after his daughter Annie's own stint in rehab.
It was because of that experience that, was still the backbone of our philosophies and beliefs at Steps Recovery Centers.
There are now 3 levels of care: inpatient, day treatment, and intensive outpatient.
You have to love doing this if you're going to do it, because addicts will wear you out.
But for those who stay strong like Allie,
You get to see that light come in someone's eyes, not because of us, but because of the work that they do.
Well, I'm with Jessica Halsey-Nickel, and she's the founder of Addiction Policy Forum. Welcome. Tell us about the Policy Forum and how you got started and why.
I founded the Addiction Policy Forum because my family was really decimated by addiction. I lost both my parents to heroin use disorder. And there's so many of us, so many families that are out there struggling alone, not knowing where to go, how to find the right help, how to recover from this illness, how to prevent this illness from happening in the first place. So we came together to build an organization to translate science, to bring all of the stakeholders to the table to work on this and find comprehensive solutions.
Are you digging into what causes addictions? Is that what it is?
Absolutely. How to prevent it and how to treat it and make sure.
I noticed you said, what did you call it? Not an addiction, but a disorder.
Yeah, it's substance use disorder.
Interesting.
That's
Tell us about how, what is that?
So the official name for addiction is called a substance use disorder. You have different types of substance use disorder, whether it's heroin use disorder, marijuana use disorder, alcohol use disorder. And it's called a disorder, not a disease, because it's complicated. It's not one virus or one bacteria that causes addiction. There's genetic risk, there's factors of how you're raised, there's trauma, early childhood trauma. Environment. The age at which you begin using substances is one of the most the biggest risk factors on whether or not you will develop a substance use disorder. So it's taking all that science and figuring out how to put it into snack packages to get it out to real people so they understand.
You know, I asked this, and we've been around the country with Sinclair and 14 town halls, and I ask everyone on the road that's involved in addiction, is addiction curable, and is it curable for everybody?
Yes, addiction is curable. It is curable for everyone. However, the longer we let this illness progress, the more damage it does to the brain. So the sooner that you can intervene and the sooner you can get help, the better your chances are for recovery. And we can prevent it among everyone. And again, that age of when you start and pushing that back is one of the best ways to protect yourself.
Is the policy, Mark, for the Addiction Policy Forum all about research, or do you do recovery systems as well?
We're about every element of a comprehensive support. So from prevention, treatment to recovery support. Recovery is a lifelong commitment to make sure you have the wraparound systems that you need to recover from this illness. So it's critical.
Now I know you have some children of your own. What are their ages?
My boys are 15, 13, and 11.
Do you speak to them about drugs and addictions?
I do. I started early and often. Even at 5 and 6 years, as soon as they were in kindergarten, we talk at our dinner table. We talk about this openly. They're pretty smart at brain science, each of their ages. I set really clear expectations, and they also know that they inherited from me, their mom, 4 generations of addiction in the family, which means that their risk is greater than their friends, and so they have to be smarter with their choices.
Are you a former addict?
I am not, no.
Does it skip generations?
No, it does not, unless you make choices and have the protective factors. So I was raised by my grandparents, taken out of foster care when I was 8. I did not use alcohol, substances till I turned 21, so I delayed the onset. I had mental health care for the early childhood trauma that I experienced. I had positive engagement like sports and church activities, because being attached to something and belonging to something healthy for you is one of the most important
Probably one of the most common things we've heard. Being attached to something healthy is the way to stay out of addiction problems. Jessica Hulsey-Nickel, thank you very much. Founder of Addiction Policy Forum. Thank you very much for your time.
Thank you for having me.
And back to you, Salt Lake.
All right, welcome back. Thank you very much for joining us. I am joined now by 2 women who have experienced opioid overdose at a very, very personal level. I'd first like to introduce Darlene Schultz. You're a family advocate with Utah Support Advocates for Recovery Awareness. And I'd also like to introduce Rachel Santizo of the Odyssey House, and you are in recovery yourself right now. So women, thank you very much for joining us. Darlene, I'd like to start with you. You lost a son to opioid addiction and overdose. Can you share with us what happened?
Sure. It was in 2012. My 18-year-old son, 4 years before that, went to the doctor at 18 years old to get a prescription for back pain. And he brought home a prescription of Oxycontin, which I was happy about because I didn't know what it was, and it wasn't Lortab, and that's what I was worried, that he would become dependent to Lortab. So when I heard Oxycontin, I thought, oh, good. And within 6 months, he became dependent on the medication, and the doctor cut him off. And he turned to the street and started paying $80 a pill. When that got too expensive, he turned to heroin. And we just spiraled from there.
Is it heroin that ended up taking his life?
Yes. After 150 days, fast forward a few years of working hard on his recovery, he hated it. He hated where he was, and he worked very, very hard to overcome this. And after 150 days of not using, he had an incidence of use, and it took his life.
How did you find out?
I was there. I found him, and we didn't have naloxone. It was in 2012. Naloxone was not available, and called 911. Felt like 15 minutes before they got there. Did CPR as long as we could, and it was too late.
And so you knew that there were the warning signs there. How difficult was it to see him struggle with his recovery efforts?
At first, it was just, I was blind to it. I didn't realize what was happening. The behaviors changed. He started isolating, and I bought drug tests, and he passed them. And it was my gut feeling. It's that gut feeling that tells you something's not right. And I was right. It was that gut feeling, and that's what I went with from then on.
Do you know how he was passing those drug tests?
No. I suspect cheating them somehow, diluting them, adding things to them. I was a naive mom that just thought I could save my son. I wanted to do anything and everything to get my son back.
So what is your message to parents out there today if they see some of the warning signs?
Don't go it alone. There's help. There's not a lot of options for families, and you don't have to walk this path alone. I tried that, and it was very hard.
And now you are part of a CRAFT program. If you could explain to me what that is.
Okay, CRAFT stands for Community Reinforcement and Family Training, and it's a non-confrontational model that we teach at USERRA to family members, and we just help you learn how to communicate with your loved one in a positive way and how to help them move toward recovery, how to step back, take care of yourself, because this is a hard thing to go through.
Mm-hmm. What's your son's legacy?
I think my goal, and I think because of him, we've gotten to this point. We wanted to bring our program statewide, and we've got 17 groups now in 10 different Utah counties, and we've also become, our group has gone national. We've trained in Texas and Nevada and Colorado, and Indiana's coming up. So I think he has helped me get this out there that families don't have to go through this alone. It's too hard.
There's help.
There's help out there.
Yeah. And that's something, Rachel, I'll bring you in now. That's something that you got. Before we get to how you got into recovery, let's talk about your addiction. What were you addicted to?
My addiction started at 24. My doctor prescribed me Loratab. Said I had fibromyalgia, and it was back pain as well. And yeah, so that's where it started.
Do you remember the first time you thought to yourself, I'm addicted to these things?
Yeah, the first time actually that I had withdrawal symptoms, I went to the ER because I didn't know what was going on, and they told me I was having a panic attack.
What were your symptoms?
My symptoms, so you get cold chills, restless legs, feel like vomiting, sometimes you do vomit.
Mm-hmm. So what'd you do?
So they gave me Ativan, and I went home, and then when I took pills the next day, it just kind of came together for me, what was going on.
So they gave you more medicine?
Yeah, absolutely. Mm-hmm.
So then what happened? You were taking the pills. Did they become too expensive?
They absolutely did. So I was taking the pills. When I found out I was addicted, I actually went to my doctor and asked how to get off of them, and she told me to wean myself. Well, going through withdrawals feels like death. It is not easy to go through at all. I would rather figure out how to keep feeding that inside than to go through withdrawals any day. I couldn't wean myself off of them. I would try, and I would say, oh, I'll try again tomorrow or my next prescription, and it just got heavier and worse as time went on.
So we were just talking about with Darlene how you need help. How did you get help? What was the tipping point for you?
So the tipping point, 7 years ago, I was that junkie downtown. I was shooting up on the street 7 to 10 times a day. I was robbing places. I was dating a guy in a gang. I lost custody of my kids. That was me, and I felt hopeless. I was scared for my life on different levels, from who I was dating to how I was using drugs, who I was hanging out with, and I got tired. I just got exhausted, and I knew that it wasn't me. The whole time I knew it wasn't me. When I was 12, I didn't grow up to be a homeless heroin addict by any means.
So how did you get help? How did you get into recovery?
So I actually looked in the phone book, and I called a whole bunch of 800 numbers. I didn't have any information on addiction, and every number kept pointing me towards the VOA, the Volunteers of America, the Women's Center.
And so that helped you out. How long have you been in recovery now?
7 years. I just celebrated 7 years last month.
People that have never been addicted, can you explain to them, are you ever never an addict again, or are you always an addict?
Always. I feel like this half of me is this junkie, and this half is this successful, fierce female that I'm meant to be. But there's things that happen, because once you get sober, then life continues to happen, and it's how you react and what you do with that. So I'm constantly making sure that I'm doing the next right thing and being the best version of myself so that I don't come back to this person.
Yeah, we've got two sides of the opioid epidemic sitting right here on this stage. You are in recovery. Darlene, you unfortunately lost a son to addiction. Very briefly, Darlene, what's the next step in this epidemic?
Oh, open your eyes. Open your eyes and get educated. The stigma's got to stop. We need to learn the language, I think, has to change as well. Instead of calling them addicts, there's someone struggling with a substance use disorder. Recovery is not about making a bad person good. It's about helping someone sick get well.
And that's about education and being honest with ourselves. All right, thank you very much, ladies, for being here today. Up next, we have some final thoughts from our experts.
losing my family, losing jobs. I was losing everything around me.
Today he's clean, but for 8 years, Travis Whitaker took opioids. Then for 4 years, he took benzodiazepines, an anti-anxiety medicine.
It all came to an end when the last, in 2009, I took 240 of them in 4 days.
And got into this car accident.
That happens to somebody that's in full-blown addiction. You know, you end up taking them all. You don't control the amounts that you're taking.
During part of his addiction, Whitaker says he self-medicated, a dangerous practice that can be hidden from routine urine sample drug tests.
So what we do is we do confirmatory testing.
That's Michael Isom of Beech Tree Diagnostics. He says unlike regular urine samples that only identify a certain class of a drug, their machines break down what drug is in the body in an amount down to the exact molecule.
So instead of it being positive or negative or pass-fail, it's, hey, I'm prescribing this, why isn't it there, and why is this in your system?
Isom then shows the detailed test results to doctors in pain management clinics. He educates them on their patients' exact long-term drug use trends.
And it's a real discussion that's happening because that's what's fueling the drug problem, is people are trading drugs, they're self-medicating.
And doing anything to get the next fix or treat the next round of pain.
Is it the next epidemic? It's already happening.
Welcome back as we are discussing about the national opioid crisis in the Your Voice, Your Future Town Hall here in Salt Lake City. I'm your host, Jim Spiewak. Joining us again, Dr. Jennifer Plum, and with the DEA, Brian Besser. Just to get some final thoughts from you, I guess, where do we go from here, Doc?
You know, I think that the key to us here is realizing how important it is to be aware, to be talking about this, to be bringing ourselves together with community resources and as with each of us from each of our different respective silos that we come from to try to make this better. We can talk about how terrible it is, and it is. We can be sad about how terrible it is, and it is. But really the key now is focusing on stories of people who find recovery, focusing on those who are trying to move towards that and help them, as well as meeting those who aren't quite there yet, meeting them where they're at. Any positive change to get people to where they feel like their life matters to our community, keep them alive, keep them going, keep them feeling supported. And I think we're really making steps and strides toward that, but we have a long ways to go.
Yeah, we most certainly do. And from science to law enforcement, Brian, same question. Where do we go from here?
You know, I get asked that question around the state as I travel, and one of the things that has really resonated with me is that this isn't an individual problem, it's not a neighborhood problem, it's all of our problem. That's the thing. This has to be a community-embraced issue. Until we holistically embrace this and we look for innovative, aggressive, and active solutions as a community, individuals will be struggling on their own. Because what I see happen is people, intrinsically think that's not my problem, it's their problem. And then all of a sudden it is. And that's what we have to do. This is a community endeavor. Until we embrace this as a state, as a community, we're just treading water.
Yeah, absolutely. I would just want to go to a couple questions here from the audience. Dr. Plum, with the 5 hardest hit counties all being rural counties here in the state of Utah specifically, are there ways to get resources and help them with emergency services, transportation, housing, things like that? If either of you have thoughts on that, Jennifer, you first.
Well, and I think that is absolutely nailing a very important piece here. As we've started, down the path of talking about this and starting to implement strategies, we're missing, and I'm the first to admit this, the fact that just keeping someone alive is the first piece. But then what about them having housing? What about them having a job? What about them having resources that help them be in a healthy place, not just physically, but everything healthy place. And I understand through the partners that are positioned throughout different areas in the state that the USDA has put in some grants in place to start working on both housing and employment positions. I know that the departments of health have also been working with local community providers to be able to do that. But that is exactly what's needed. It's enough to talk about it, but to actually then walk the walk is where we're going to keep people in the right path.
Yeah, and it's a tough conversation to have, Brian, because as we've talked about before, I mean, this is a difficult subject, difficult questions to ask and difficult answers from the law enforcement perspective. How much in the rural areas are you seeing this perpetuate?
The rural areas are getting hit really hard right now, especially in Utah. Carbon, Emery, Beaver counties are getting just hammered with this problem. You know, going back to something my dear friend Darlene said, it's about restoring people to wholeness. And that is a concept oftentimes that we have to really take a look at. How do we do that? Like Dr. Plum said, we need to think outside the box. We need to get creative. Many of these individuals that are quietly struggling in the prisons of their own mind with substance abuse feel that they are second-class citizens. They don't have the work opportunities. They don't have the health care opportunities. They don't have necessarily the resources that are at their disposal. If that is exactly opposite what we want to portray. We want to get as many resources, as many facilities, and lend a hand to these folks to help them up and get them whole again.
Real quickly, how many, we're talking about children. A lot of questions are coming in about children. In your line of work with the DEA, are children being introduced to this at a younger age, and are they getting their hands on prescription pills at a much younger age?
Well, I can speak to that from working in the emergency department. I work in pediatric emergency medicine, and I had one night where I had 4 children between 0 and 4 all overdosed on opioids from within their home. So when we talk about introducing, it isn't always just, the thought that they're introduced, outside of their parental controlled world. We have a lot of pills in this state, and we have a lot of kids in this state, and they find things. And so when we talk about it, it is simply a reality that anytime you have a kid, you know what they'll do, right? They'll put stuff in their mouth, regardless of what it is. And so on just the medical side, I can tell you, we see it in children less than a year of age even.
What about in like elementary or middle schools?
Yeah, it's heart-wrenching. We are in thousands of homes during the year. And you innately bump into kids who become the innocent third-party victims of what's going on with mom and dad. More so, I go back to my comments about America having an insatiable appetite for drugs. We treat dangerous drugs almost in a benign fashion in our culture anymore. In fact, in the movies and in Hollywood, it's oftentimes just portrayed as a way of life. And we are seeing, especially on the DEA side, I am seeing the average age of kids, for instance, being exposed to and starting to use marijuana at age 11. That's about the average age. So it's no surprise to me that these children oftentimes end up starting their cycle of addiction with other drugs, and then they, segue over to harder drugs like opioids and heroin.
And if they see their friends do it, do they start doing it?
I mean, there certainly is that peer influence that happens in all sorts of childhood behaviors, right? Whether it's wearing your helmets or experimenting with substances or, all kinds of kid behaviors. That's kind of, we love to learn from our peers. And I think, too, one of the things that's a big piece of this, there's so much, again, coming back to the stigma and shame, families that have children that are absolutely terrified to ask for help because of fear that their children will be taken away from them.
I don't have much time left, and this is an impossible question, but I want to ask both of you real quickly. Will we ever see an end to the opioid epidemic?
An end. That's a hard term, isn't it? An end.
I tell people this, until America changes the way we self-medicate, until we change our pain management paradigm in this country, I don't know if we will. We're out here in the trenches, we're passionate about it, but America has to change from within.
And from a science perspective, is there a way to do that, do you think? I know, it's an impossible question.
It really is an impossible question. In my dream world, yes, I would love to say that Americans don't just assume there's a pill for every ill, and physicians take the 45 minutes to talk about how painful life is instead of the 15 seconds to sign a prescription, and pharmaceutical companies stop marketing something that really is only about dollars to them, which is skull and crossbones on the other side. I do foresee the possibility, but I think we're talking about generations before that actually is even possible.
And you're talking about a lot of stakeholders in play to all be on the same side and agenda. All right, Dr. Plum and Brian Besser with the DEA, thank you very much again. We want to now go to Eric Bowling for some final thoughts.
What a great town hall. Again, we're eliminating the stigma of opioid overdose and death in America. That will save lives. Again, to the kids, one pill can kill. You guys don't know it, what it is. If you put something in your mouth, it may kill you. It happened to my beloved son, my Eric Chase Bowling. I adore him still to this day. To parents, have the discussion with your kids. They're not too smart. They're not too popular. They're not too pretty. They're not the captain of the football team. It doesn't matter. They will cross their paths at some point. I want to say thank you also to Dr. Jennifer Plum. I'd like to say thank you also to Brian Besser, DEA agent, Assistant Attorney General Scott Reed, Darlene Schultz, Rachel Santizo, Jim Spiewak. Thank you very much, Jim. Also to Sinclair. What a great collaboration. KUTV, been fantastic. Liberty University, our partners there. And please don't forget to watch America This Week on your local Sinclair stations. Good night, everybody.
To know where we are right now in this opioid epidemic, it's important to know where we came from. If you go back to the early 1800s, that's when a scientist isolated morphine out of the opium poppy seed. That's essentially where, in modern times, where this all started. You fast forward to 1870s, and that's where heroin was derived from morphine. And it took almost 100 years after that when man-made synthetic pills, as we know them today, were created and really thrown into society. Now, the CDC says that they do a lot of good, but they also say, on average, 130 Americans die every single day of an opioid overdose. We started this town hall talking about how do you control an epidemic? Well, it's about education and it's about knowledge. I hope that you had a chance to learn just a little bit of that during this town hall. I want to thank you again for joining us. I am Jim Spiewak, your host. Thank you again. Good evening.
It is a nationwide crisis impacting every one of us. Opioids, legal and illegal, they're addictive and deadly.
This epidemic is a national health emergency.
Lives are being lost by the tens of thousands every year to painkiller abuse and heroin. The financial impact is in the billions. Opioid issues knife across each state, endangering every American city, suburb, and town, all cut deeply by the opioid epidemic.
We must commit to removing the stigma of shame that comes with addiction and helping change public opinion so that people find evidence-based treatment before it's too late.
Stand up and fight the opioid crisis now. Opioids, a national crisis.